Today our topic is cardiac harassment and assessment. Assessment of the cardiovascular system is one of the most important areas of the nurse's daily patient assessment. Report your findings as clearly as possible. Charting your results clearly is essential for others to be able to assess the problem, and good documentation is also essential for the treatment of the patient as well as the nursing care. Physical examination and evaluation. Physical examination in general, we should speak about the obesity or wasting, shortness of breath, difficulty in talking. Note whether they took ill. Look for pallor, jaundice, wettiness, and clamminess, and for exophthalmia around the eyes. Cyanosis. This is seen below the fingernails and tonsils to nails, but also in the lip, cheek, ear, and nose. It may increase in the cold and exertion. Face. Male flesh. This is a redness around the cheeks. Mitral stenosis. Xanthomata, yellowish deposits of the lipid around the eyes, palm, and tendons. Hyperlipidemia. Corneal arcus, a ring around the cornea. Normal aging or hyperlipidemia. Proptosis, this is a forward projection or the displacement of the eyeball. Graver disease. In case of hands, we should see the finger clubbing. Janeway lesion, this is the macules on the back of hands. Infective endocarditis, osseous nodules, like tender nodules in the fingertips, infective endocarditis. In case of pulse, check whether the average 72 per minute in the adults, faster in the children and may slower in the age and slower in the athletes. Compare with the apex rhythm. The respiratory variation are common in the healthy individual. If there is a noticeable quickening in the inspiration and slowing in the expiration, this is termed sinus arrhythmia. Peripheral pulses, the femoral pulses, radial femoral delay in the contraction, and the foot and the ankle pulses. Listen over the renal and the femoral artery for the murmurs. Check the blood pressure. This should be measured in the brachial artery using the cuff around the upper arm. A large cuff must be used in the obese people because a small cuff will result in the blood pressure being overestimated. The systolic pressure is at the level when first heard, cat of 1, and the diastolic pressure is when silence begins, cat of V. That is the fifth one. In patients with a chest pain or if ever the radial pulse appear asymmetrical, the pressure should be measured in both arms because the difference between the two may indicate the aortic dissection. Check the level of the jugular venous pressure. Chest examination. Look to see if the chest wall is deformed, funnel chest, and moves equally. Inequality of the expansion is usually due to the respiratory disease. Note the respiratory rate. It is related to the pulse rate in the ratio of about 1:4 and remains constant in the same individual. Ask the patient to breathe out and using the both hands resting lightly on the side walls of the chest with thumbs meeting in the middle. Ask them to breathe into the assess the expansion of the chest and full inspiration by nothing. How far the examiner's thumb move apart. Feel over the anterior chest wall for any thrills associated with the cardiac murmur, auscultation of the heart, etc. Abdomen. See also separate abdominal examination. Palpate the abdomen for the hepatomegaly and splenomegaly, congestive cardiac failure or spleen alone, infective endocarditis. Feel for the enlargement of the aorta, aneurysm. Feel with the hands flat either side of the aorta. Feel for pulsation and the tenderness. Investigation. This may include the blood test for fasting the glucose and for the hemoglobin, renal function, LFT, TFT, lipid profile, cardiac enzyme, ESR, and CRP. 12-lead ECG and ambulatory ECG monitoring, exercise ECG testing, ambulatory blood pressure monitoring, chest X-ray, spirometry, echocardiogram, cardiac catheterization, and angiography. Echocardiography, ECG or EKG. This is a process of recording the electrical activity of the heart over a period of time using the electrodes placed on the skin. These electrodes detect the tiny electrical changes on the skin that arise from the heart muscles' electrophysiologic pattern of the depolarizing during each heartbeat. It is a very commonly performed cardiology test. Main pattern. The 12 lead ECG is used to classify the MI patients with one of the three groups. Those with the ST segment elevation of the new bundle branch block the suspicious for the acute injury and the possible candidate for the acute repression therapy with thrombolytics or primary PCI. Those with the ST segment, the depression or the T wave inversion, suspicious for the ischemia, and those with the so-called non-diagnostic or the normal ECG. However, a normal ECG does not rule out the acute myocardial infarction. Assessing the cardiovascular system, we should consider the health history, that is the current health status like chest pain, shortness of breath, swelling of ankles or feet, heart palpitations and fatigue. Past medical history: congenital heart disease, rheumatic fever, heart murmur, high blood pressure, high cholesterol, diabetes mellitus, confusion and fatigue. Personal habits: cardiac assessment. In the techniques of the examination, the patient should be supine with the upper body elevated at a 15 to 30 E angle. The room must be quiet, warm and have a good lighting. You should stand to the right of the patient being examined. Inspection and the palpation of the heart. The finger pads are more sensitive in detecting the pulsation. The art of physical examination using the techniques of inspection, palpation, percussion and auscultation. Pulsation: these are more visible when patient are thin. A quick thick chest wall or increased AP diameter can obscure them. Pulsation may indicate the increased blood volume or pressure. Lift or heaves. These are the forceful cardiac contraction that causes a slight to the vigorous movement of the sternum and ribs. Thrill: these are the vibration of the loud cardiac murmur. They feel like throat of a purring cat. Thrills occur with the turbulent blood flow. All people enjoy the time machine, that is aortic, pulmonic, ERB point, tricuspid point, mitral point. These are the 5 areas for listening the heart. Aortic, the second intercostal space to the right of the sternum. A pulsation could indicate the aortic aneurysm. A thrill could indicate the aortic stenosis. In the pulmonary region, second intercostal space to the left of the sternum, pulsation could indicate the pulmonary hypertension, pulmonary stenosis. Tricuspid, fifth intercostal space, lower half of the sternum. A sustained systolic lift could indicate the right ventricular enlargement. Thrill could indicate the ventricular septal defect. Mitral, fifth intercostal space at the mid-clavicular line. Increased pulsation could indicate the increased output. Anxiety, fever or pregnancy. A thrill could indicate the mitral regression or mitral stenosis. Epigastric, below xiphoid process. Increased aortic pulsation could indicate the right ventricular pulsation of the right ventricular enlargement of the aortic regurgitation. Sternoclavicular, top of the sternum and the junction of the clavicles. Pulsation of the aortic arch may be felt in the thin client. Aortic area, the second right interspace close to the sternum. Pulmonic area, second left interspace. ERB point, third left interspace. Tricuspid area, fifth left interspace close to the sternum. Mitral wave, which is apical, fifth left interspace medial to the MCM. Aortic, the second ICS. Pulmonic, second ICS. ERB point, third ICS. Tricuspid, fourth or fifth ICS. And mitral or apex, fifth ICS. Auscultation of a heart with a stethoscope. With a stethoscope, identify the first and the second heart sounds S1 and S2 at the aortic and the pulmonic area base. S2 is normally louder than S1. S2 is considered the dub of lub dub. S2 is caused by the closure of the aortic and the pulmonic veins. Identify the heart rate, tachycardia and the bradycardia. Identify the rhythm. If it is irregular, try to identify the pattern. Do yearly beats appear on the regular rhythm? Does the irregularity vary consistently with the respiration? Is rhythm totally irregular? Listen to the S1 first and then S2 at the previously mentioned area using the diaphragm and then the bell. Note its intensity. Are there any splitting sounds? Check during the inspiration where S2 usually splits at the pulmonic and the ERB point. A thick chest wall or increased AP diameter may make the S2 inaudible. Alteration in S1, S2, S3 and S4 and normal. Inaudible S3 is normal. Audible S3 may be abnormal. Thank you.